Yesterday, we discussed a case with an unstable patient in the PACU diagnosed with a tension pneumothorax. Needle thoracostomy with an 18-gauge IV catheter resulted in no rush of air. So what happened next? The clinician removed the 18-gauge IV catheter and replaced it with a 16-gauge IV catheter, but again, no rush of air was observed. Next, the team removed that catheter and placed a 14-gauge IV catheter in the same location, now with an audible release of air, resolution of the pneumothorax, and improvements in O2 saturation. So what exactly had happened? Well, it turns out that both the 18-gauge and 16-gauge catheters had integrated anti-reflux valves designed to prevent blood from leaking backwards during IV placement and to prevent needle stick injuries. The 14-gauge catheter did not have such a valve, and that's why the release of air was heard. The patient ultimately did well and was discharged home 3 days later. In part 3 of this series, let's talk about how to manage emergent needle decompression of tension pneumothorax, including lessons learned from this case. To read the entire case, go to apsf.org and the Articles Between Issues section.